I will present on a study based on a Delphi study, which is strengthening multi-sectoral coordination in Ethiopia. As you know, in Ethiopia, the nutrition sector has a bit of challenge in terms of coordination and leadership. So this study aims to build a consensus of experts and leaders in the field on how to strengthen the multi-sectoral coordination in Ethiopia. This will be the agenda for my presentation. As a background, nutrition is, as you know, it has become almost everyone's business. And there are different sectors in the nutrition who are currently implementing or supporting the nutrition sector in Ethiopia. But the problem is sectors are working in silos, or they are working with little coordination or little integration, and there's lack of uniform monitoring and evaluation system. And there is a lot of challenge in terms of some competition and also competitive ideas in terms of the coordination. So this study tried to build expert consensus using the Delphi approach or the Delphi technique. How can we best coordinate the nutrition sector in the country? So just moving to the methodology, we use a Delphi technique. For those of you who might not have conducted the Delphi study, it is a multi-stage, multi-round study, the first, second, and third round study. In the first round, what we do is we collect qualitative ideas from the respondents. And based on the first round, we build our second round or the second round of questions. The first round are based on the researchers, but the second and the third round are based on the respondents of the response of the respondents. And it is iterative, multiple rounds, up to 3 rounds, and the aim is to build a consensus of experts who can work on this one. So what we have done is we selected participants with more than 5 years of experience in nutrition coordination in the country, and we included experts from Ministry of Health, Ministry of Agriculture, Education, WASH, Social Protection, and Planning. And from UN agencies, NGOs, and bilateral partners were also involved, and national, regional, and zonal level, as well as even world level experts were invited to participate in this consensus building study. So a total of 24 were invited and 80 responded with a 75% response rate during the first round. And in the second round, from this 80, 50 participated with more than 83% response rate. We didn't conduct the third round because we were able to get consensus in the second round. So the third round was not needed, and we stopped in the second round of the Delphi study. So when you see the results, we identified 9 overarching themes during the first round of interview or online survey, including governance and leadership issues, intersectoral dynamics, subnational capacity, finance, monitoring and evaluation, data platforms, institutions, and the like. So we identified 9 overarching themes, and we sent or organized these questions in the Likert form and sent back to the same respondents, and we obtained 57 reflecting barriers and answers or statements reflecting barriers, enablers, as well as strategic actors. And a mean score of 4 was considered as a consensus, and we've made almost all of the responses for these 57 statements in the second round. So as you can see, the highest score was found in terms of finance and HR, monitoring and evaluation, and data use, data platforms, and little about less consensus on governance, intersectoral coordination, and subnational level issues. Coming to the results or the barriers in terms of the study, the first barrier was governance and leadership. That means there was lack of clear, impartial leadership for nutrition in Ethiopia. That was found a common consensus for almost 4.64 out of 5 responses. And the other barrier was, neutral, high-level leadership was the other challenge we found. Positioning coordination in a politically neutral apex of body, or the Prime Minister office, for example. So the first challenge or the first barrier was found to be lack of neutral and strong leadership for nutrition. So sorry, this one is. Governance was the first challenge. The second barrier was intersectoral dynamics and subnational capacity. Entrenched silos and egoism between sectors, particularly the Ministry of Health and Agriculture. One of the respondents said that, a respondent from none of these sectors said that there is no policy that hinders, but the egoism of the health and agriculture led other sectors to remain quiet, showing that there is still a conflict of interest between especially the Ministry of Health and the Ministry of Agriculture. And non-health sectors often see themselves as peripheral rather than part of the coordination or the overall nutrition governance in the country. The third barrier was subnational capacity. In terms of implementing nutrition activities at subnational level, there were many regions or woredas with lack of functional nutrition structures, or there was no single structure at the grassroots level which is able to deliver nutrition service, except the health extension program, which is mainly overburdened by other services. So inadequate staff, high turnover was found to be the third. So these are the 3 leading challenges that we identified from the Delphi study. In terms of the enablers, the first one is leadership. As I've said, they suggested that there should be a high-level, politically committed leadership which can coordinate nutrition instead of led by different sectors. Positioning it in a high-level body like in the Prime Minister's office or Ministry of Planning was suggested. The second was the presence of additional finance, human resources, and capacity is needed for the nutrition sector. Suggesting for ring-fenced domestic budgets for coordination at all levels and technically trained and dedicated focal nutrition personnel in sector, especially coordinating the nutrition programs. The other one is monitoring, evaluation, data use, culture, and digital platforms. This was also another enabler. The presence of a unified common result framework or dashboard was suggested by the respondents or the experts involved. I want to emphasize this one. This was mentioned in several of the responses. Common results framework. I mean, there is no common results framework. Every sector does its own business. So there is a need for a common results framework in terms of strategic objectives, in terms of ensuring aligning the sector's activities, and clear outputs with led sectors and illustrative indicators, as well as unified digital dashboard is needed to ensure that nutrition performance are measured, monitored, and evaluated. So aligning targets, indicators supporting across sectors, and also supporting joint reviews are ensured by the presence of a common results framework, which was the main result. So coming to the end, what are the priority actions which we found from this study? The first one is legal and institutional reforms. They suggested that there should be a neutral body which can coordinate nutrition. Instead of being something in the Ministry of Health, something in the Ministry of Agriculture or somewhere, there should be some high-level body coordinating nutrition and codify multi-sectoral nutrition roles in laws and regulations were also suggested. The second is in terms of finance, more budget, more ring-fenced budget from the government for nutrition is needed because most of the supports are coming from donors, which cannot be sustained. The third one is, as I've suggested, data and common results framework is needed. Deploy a unified digital common results framework or dashboard and ensure interoperability of sectors in terms of their activities and their monitoring and evaluation work. And also subnational committee level personnel and structure are also needed. So in conclusion, Ethiopia has strong policies, as you know. We have a lot of policies, strategies, but in terms of finding a clear result at the grassroots level, we have several limitations. Coordination is still constrained by leadership gaps, weak subnational capacity, fragmented data, underfunding, and all these are the challenges. So we need a multi-sectoral nutrition coordination body that is institutionalized, well-financed, data-driven, and not project-based to end the huge burden of malnutrition which our country is facing. So this is just a brief of what we have reported in our detailed report. I thank you for listening.
Thank you, dear Dr. Tadesse, for your wonderful presentation. Strengthening sectoral nutrition coordination in Ethiopia with the Delphi technique. So next presenter will be Sisai Shine from Debre Bryan University. His study focused on maternal fine particular matter exposure and its impact on pregnancy. So let's give him a chance.
Okay. Thank you. My name is Sisai from Debre Bryan University. I'm a PhD student in Addis Ababa University. Yes. Okay. My title is Fine Particulate Matter Exposure and Adverse Pregnancy Outcome in rural Butajra, Ethiopia. Cohort study. So I will follow this presentation outline, and as an introduction, adverse pregnancy outcome is a major public health problem globally, as you know. This problem is 90 from total birth outcomes, around 19.8% were low birth weight, and more than 30% were also stillbirths, and preterm births, and stillbirths also be around 2% of the new births were stillbirths, and overall this adverse pregnancy outcome, more than 90% of this adverse pregnancy outcome is found in developing countries. In Ethiopia, as you see this bar chart, the problem is still severe, and the overall adverse pregnancy outcome is more than 26%, and low birth weight is around 10%, and the preterm birth and stillbirth is around, it's also be a major public health problem in Ethiopia. And the cause of this adverse pregnancy outcome is different, like that of socio-demographic characteristics, obstetric and psychological factors. Majority of those things are well studied, and you can find different researches, but there are another factor which cannot be that much addressed about this adverse pregnancy outcome, like that of environmental factors, which is particulate matter or air pollution exposures. So particulate matter have ability to enter to the respiratory system and blood circulation, and prolonged exposure of this particulate matter causes, like this exposure is the cause for maternal oxidative stress and inflammation and coagulation and blood system alteration, and reducing the placenta blood flows and interfere with transplacental oxidation. This will lead to the adverse pregnancy outcome, like that of low birth weight, stillbirth, and preterm birth. And globally, there is an effort to reduce the deaths and illness related to this air pollution from the Sustainable Development Goal 3, and that was target 3.9 by 2030. And Ethiopia also working towards these targets by promoting improved and clean household energy. Despite the distribution of this improved cook stove in Ethiopia for the past 3 decades, the problem of this particulate matter exposure is still high, and the adverse pregnancy outcome is still the persist, and particularly in rural area. However, no studies have been determined the association between maternal particulate matter exposure and adverse pregnancy outcome. So the objective of this study is assessing the association between this particulate matter exposure and the adverse pregnancy outcomes. These are a method that we used. Study design prospective course study from March to August, and sample size around 328 pregnant women were recruited as a starting and followed until delivery. And the study participants are pregnant women, and the outcome variable is adverse pregnancy outcome, like that of low birth weight, stillbirth, and preterm birth. And exposure, the main exposure variable in this study is the mean particulate matter exposure levels. And we also identified those confounding variables, like that of socio-demographic characteristics, maternal, fetal, environmental characteristics, nutritional related characteristics also be assessed to control as a confounder. And data collection method, interview and observation by using structured questionnaire were used to assess the socio-demographic housing characteristics. And particulate matter exposure were assessed for 24 hours for 3 times, repeatedly. We measured throughout pregnancy at 20, 30, and 30 weeks of gestation. And birth outcomes were recorded from the health facility within 72 hours of delivery at health facility. Data analysis, we used logistic regression, and Poisson model was used to estimate the relative risk with 95% confidence interval. These are the socio-demographic characteristics of the study participants, like that of the mean age of the study participants is around 29 years, and nearly all were married in that participants. Majority were housewives. It's more than 93% were housewives. So the mean and the median particulate matter exposure level among pregnant women in this study area is look like this, like that of about 20, 30 weeks, and 36 weeks of gestation. The mean particulate matter exposure is look like this. This mean particulate matter exposure level of among pregnant women is highly different by using across different variables, like that of socio-ecologic variables, wealth index, type of fuel used, and roof material that the house used. The mean particulate matter exposure level is different across these variables. Here it is the hourly particulate matter exposure level among pregnant women within the different gestations. Like that of, you can observe, here it is the peak exposure level of the particulate matter. At the early morning and at the early evening, the particulate matter exposure were high due to different reasons. Majority of the activities, the coffee ceremonies and etc. is conducted at this period of time. Even if there is an activity, such activities are found within at daytimes, but majority of the time the house are open, the windows, the doors are opened, but at the early evening and at the early morning, those windows and the doors are closed, and they do their activity at the night and at the morning time. That's why this particulate matter exposure is high. As you see, based on their gestational age, the green one is the 36 weeks of gestation, and the blue one is at 20 weeks, and the the orange one is at the 30 weeks of gestations of the particulate matter exposure. This particulate matter exposure is higher at the 36 weeks of gestation and at 20 weeks of gestation, rather than that of the 30 weeks of gestation. 20 weeks and the 36 weeks of gestation, the particulate matter exposure is high. This may be due to that the women's at the early gestation, there is nausea and it is symptoms of illness among women. That makes the women stay at houses so that they more exposed for this particulate matter. And at the 36 weeks, the particulate matter also be high. That's maybe due to when the gestation age of the pregnant woman increased, she becomes stay at house with their day-to-day activities. That makes the particulate matter exposure high. Whereas in 30 weeks, this symptom of pregnancy relief, there is a relief, so they can move outside, and she may want, or she may find those refreshed air at the 30 weeks, so that this particulate matter exposure is lower at 30 weeks compared from the 20 and 36 weeks. This is the things. And when it comes to the incidence of adverse pregnancy outcome, it looks like this from the study area. The overall adverse pregnancy outcome is around 18.2%. Preterm birth and low birth weight, spontaneous abortion, and stillbirth, it look like this in the study area. This is comparable with the studies in a different area of Ethiopia, like that of the same study areas, as well as in southern Ethiopia. But majority of those studies are the hospital-based studies rather than the community-based studies. And however, the study also be in southwest lower than the study from southwest, northwest Ethiopia, and the pooled prevalence studies. This may be due to the difference across this study, may be due to the majority of those research was conducted from the secondary data from health facilities, particularly from hospital, where those adverse pregnancy outcome is higher, proportional pregnancy outcome treated in the hospitals. Okay, the maternal particulate matter exposure and pregnancy outcome association. You can see this, the relative risk for low birth weight and overall adverse pregnancy outcomes among pregnant women. For every interquartile increase in maternal particulate matter exposure, the risk of low birth weight increased by 1.2 and the overall adverse pregnancy outcome by 1.1 times higher. It is consistent with the study conducted in Africa, overall Africa, as well as meta-analysis studies in different parts of the world, and Peru and Finland. This may be due to particulate matter can be penetrating into the lung and enter to the bloodstream and reducing the systemic oxidative stress, and which can leads to inflammation, trigger placental inflammation and particular vascular dysfunctions, and impair placental function, leading to reducing the transfer of the nutrients to the fetus, disruption of placenta hormones, and reducing the oxygen system delivery to the impaired placental blood flow. So as a limitation of this study, the study was conducted in rural population where particulate matter mainly originate from the biomass fuel. This may be limited to generalizability of the finding to the urban areas. And sometimes some outcomes like that of the abortion, spontaneous abortion, and stillbirths are rare. Low event frequently reduce the statistical power to detect significance association. As a conclusion, maternal particulate matter exposure remains an important environmental risk factor during the pregnancy, and maternal exposure to particulate matter was significantly associated with overall adverse pregnancy outcome, and no association or significant association observed between the particulate matter exposure and preterm birth. It may be due to the sample size issues, but majority of the study have an association with preterm birth with this particulate matter, the preterm birth and particulate matter exposure. Public health action intervention were needed to reduce pregnant women's exposure to particulate matter exposure, especially for rural areas where biomass fuel use is common. That's, I think, it's all. Thank you.
Thank you, Sisai, for your presentation. So we will continue with the next presenter, who will be Twerk from Debra Brahan. Her presentation will focus on quality of antenatal care, which is a meta-analysis study. So let's give her the stage.
Thank you. Good morning. I am Twerk Ismail. Now I am going to present my research work on the title of Quality of Antenatal Care Service, a systematic review and meta-analysis. Here is the presentation outline, introduction. method, result, and discussion and conclusion. ANC is a critical determinant of maternal and neonatal health, especially in low and middle income country. However, its effect, the ANC effect is determined by its quality rather than on the mere coverage. But it is difficult to quantify the quality only because of the complex nature of the concept, and it is challenging to measure it directly. And also researchers have followed several approaches to measure the quality of ANC coverage. So therefore, this systematic review and meta-analysis is to synthesize the existing evidence on the method used to measure the quality of ANC service, and also it provides a full estimate of the overall level of ANC quality globally. So we have used this, the condition, context, and population to prepare the searching term to search the studies from, here is the logic grid. We use condition as quality of antenatal care service, quality of prenatal care service, and quality of maternal care service used as a condition, and we have not specified the context because we use at a global level study, and women, mother, female, and pregnant were considered as a population. Finally, we have prepared this searching term to search the studies. Here is the Prisma flow chart diagram describing the selections of the study, which included in our final analysis. First, we have found 9,627 studies, and we exclude duplication, due to duplication, 2,151 studies, and finally, we have included 88 studies. Among 88 studies, 14 of them were used for the methodological synthesis, and finally, we used 74 studies for the quantification analysis. So among the total 88 studies, 40 of them were conducted at facility-based, and 47 were community-based, and one combining both facility and community-based. And when it comes to in the study design, around 80 of the studies were used cross-sectional approach, and 9 studies were followed the cohort study approach. And when we see in the data source, 41 studies were used primary study, and 47 studies were used secondary studies, secondary data to quantify the quality of ANC service. And when we see the outcome measurement, as we know, the quality has 3 approaches: as the structural quality, the process quality, and the outcome quality. When we see the outcome measurement approach, the 75 of the study were used analyze the process quality only. 1 study was conducted structural quality, 2 of study were outcome quality, 7 study were used both structured and process quality, and 3 of study were conducted structure, process, and outcome quality. And when we see the studies, how to quantify the quality of ANC, 44 studies were used as consider a quality of ANC if the women's taken all service during the ANC service, and 11 of the study were used as a cutoff point 75% or 17 percentile, and 2 study were used 80%, 1 study were used 70%, and 3 studies received at least 5 service out of 6 service, which means 3 of them, the study used as 6 indicators to measure the quality of ANC. Yeah, here is this is the overall quality of the quality level of ANC globally. There was high heterogeneity among studies. The studies are 74, which include in this the quantitative estimate, the global pooled estimate of quality of ANC service coverage, or 35%, which means around 2/3 of women doesn't receive quality of ANC globally. And also we have conducted subgroup analysis by continent, study design, study setting, and quality of ANC dimensions. There is a discrepancy between the quality of ANC coverage among continents, study design, study setting, and the quality measurement dimensions. So the finding reveals that making different in coverage the quality of ANC among the continent. So this variation may be in the health infrastructure, policy implementation, and the population level determinants may be affected by affects the coverage of quality of ANC. And cohort study reported higher pooled quality of ANC coverage than those reported in the cross-sectional studies. This may be attributed to cohort study follow women across the pregnancy continuum. So this may be more comprehensive and accurate assessments of care received. And also the cross-sectional study may be influenced by the recall bias. And also facility-based studies have reported slightly higher estimated quality of ANC coverage than the community level studies. And also this variation may be due to the recall bias, and also the variation may be because of facility-based studies applied structured data collection system, and which may be able to provide full documentation as compared to the community-based studies. And also, on the other hand, community-based studies usually more inclusive of the marginalized and hard-to-reach population, even if the quality measurement is it may be limited to capture the quality of the structural quality and the outcome quality. So regarding on the methodology employed to measure the quality of ANC, outcome quality assessment had a higher coverage compared to the process quality and structural quality. This outcome quality measured rarely be the end result, because the outcome quality is measured by the effect of the ANC on the mother and the neonatal health. So it may be that affected by the positive bias. In contrast, the process quality and structural quality are assessed through more objective and standardized criteria, which may be highlight actual deficiencies in service delivery. So as a conclusion, majority of the study includes focused on the process quality, as when we see in the quality dimension as the process, the structural quality, the process quality, and the outcome quality. Most of the studies were focused on the process quality rather than the structural quality. More than 2/3 of pregnant women doesn't access quality of ANC service globally. And the pooled estimate of quality of ANC service was varied between continents, and also substantial variation in the estimated coverage of quality of ANC service across studies in different design and setting. So, finally, I would like to say thank you, Ethiopian Public Health Association, for giving this chance to present my work. My supervisors, Professor Sekabeda, Professor Tamasgan, and Dr. Gadafau, and Bardar University. I came from Bardar University, not Darul Khan.
Thank you, Liltwork. There are some presentations. If Desta, Dabalke, Abebe, Dele, Nkunat Nafu, if you are around, please let us know. Okay. Presenters, please come around here.
Okay, thank you. My presentation is entitled, Does Life Expectancy Vary by Disability Status, Lower and Income Countries? A Systematic Review and Meta-Analysis. This is the outline of presentation I am going to follow. As introduction, over 60% of the global population lived with some form of disability, where 80% are found in lower income countries with poor health system, where healthcare delivery system is more marginalizing those people with disabilities. This population is increased by population growth and aging. On the other, moreover, people face a range of exclusion from accessing healthcare due to a number of factors associated with policy-related, infrastructural, attitudinal, and other barriers. Consequently, they experience poor health status that's associated with their underlying impairment. Their underlying impairment, secondary conditions, and comorbidities. Therefore, they have an elevated risk of morbidity and mortality. As a result, they experience a higher reduced life expectancy compared to others in the population. For example, a global evidence shows that people experience about 10 to 20 years life expectancy gap compared to others in the population. However, evidence are very limited in lower income countries. That summarizes the life expectancy in a comprehensive way. Therefore, this study will address how disability reduces or increases life expectancy in people with disability compared to others in the population. We are also pull the years of life lost in people with disabilities compared to others in the population. This is a meta-analysis by design. We develop a protocol and register in Prospero according to the PRISMA guideline. A such strategy was developed using various key terms, mesh terms, and vocabularies related to disability, lower and income country life expectancy, using the Boolean operators like and, or not. Finally, we search electronic databases for a number of records, and then we got about 8,746 records. After we got these records, we transferred to electronic, the internet bibliographic reference in order to duplicate what? In order to remove the duplication, then we perform screening strategy using the eligible criteria as displayed here in the slide. Finally, we got 12 articles for final analysis. Then we perform analysis using the software, the Meta4 package, and the heterogeneity of the distribution of data was assessed using Cochrane Q-statistics reported by chi-square index and p-values. Fortunately, the distribution of the data among the included study was by nature heterogeneous, so that we fitted random effect model using the restricted maximum likelihood method in order to estimate the pool mean life expectancy and year of life lost in people with disability compared to others in the population. Therefore, we perform subgroup analysis in order to identify the potential source of this heterogeneity in terms of summarizing life expectancy in people with disability compared to others in the population. We also fitted a meta-regression analysis, both univariable and multivariable regression, so that we know how much the individual characteristics or moderates are explained the built model in terms of summarizing the life expectancy. We also assess the publication bias both objectively and subjectively, and also assess the heterogeneity subject using the forest plot diagram. Results, most of the included studies is carried out in China and also in the WHO region of Pacific region. Most of the included participants was people without disability, which accounted about 74% of the sample size. The study design is longitudinal observational study, where 9 study of the included articles are reported life expectancy and year of life lost concurrently. Most of the studies deals with about psychosocial impairment, cognitive and neurological, as well as multiple impairment. When it comes to the pooled estimate of life expectancy versus years of life lost, people with disabilities experience very low years of life expectancy compared to people without disabilities, as seen here in the forest plot. And the distribution of data among the estimate is also very varied. It may be attributed to smaller sample size or the underlying conditions that people experience as compared to those without disabilities. And this study was also varied by gender when we carry out a stratified analysis. The years of life lost among people with disabilities is about 16 years compared to others in the population. And the distribution is also highly heterogeneous. And this was also comparable to other studies carried out in the world, particularly lower-income countries where health systems are very discriminatory against people with disabilities. Therefore, in order to know the potential source of heterogeneity, subgroup analysis was carried out using a number of characteristics. Among them, only WHO regions and publication year was, WHO regions was the most significant, where people with disabilities who live in the regions of America, particularly those studies found in the Brazil, showed a higher reduced life expectancy compared to other WHO regions like African region, Western Pacific region. When it comes to the meta-regression, in order to identify the association of each individual moderators or individual characters that built the model with respect to heterogeneity, we performed both univariable and multivariable meta-regression model. However, in the univariable meta-regression model, only 2 of the moderators are associated with the heterogeneity that built the model that is estimating the pooled years of life lost in people compared to others in the population. So life estimation methods explained only about 35% of the variability that built the model to assess the pooled life expectancy. Years of life lost in people with disabilities. And that of source of data explained only 57% of the variability. When it comes to the multi-regression, all potential modellators explained only 76% of the variability that used to estimate years of life lost in people with disabilities compared to others in the population. This estimation is very robust, where most of the variability are explained by the moderators built the model. The rest 24% was still not yet explained, the variability in terms of characterizing the full life expectancy in years of life lost among people with disabilities. In conclusion, disability substantially reduced life expectancy in years of in lower and middle income country. Therefore, average life expectancy people with disability is very low compared to people without disability, and this evidence also vary by gender. Therefore, inequality in use of life lost and life expectancy still demonstrates that there is a health system failure that used to include people with disabilities in every aspect of health efforts. Therefore, health program has to be piloted and integrated towards inclusive healthcare delivery so that people with disabilities could not be left behind in terms of addressing the global targets like Sustainable Development Goal, universal health coverage, and health and other targets so that people with disabilities could not be left behind in terms of addressing this global effort. I thank you so much for London School of Hygiene and Tropical Medicine for this study.